Hey everyone, and welcome back for another deep dive. Today we are going to be tackling a topic that you requested, and it's a pretty dense one, pulmonology. You sent over a whole chapter from a medical textbook, and it seems like you want the full rundown. Theories, research, case studies, the whole shebang.
It's quite a journey into the lungs and the respiratory system. We have a lot to cover, but I think it'll be fascinating.
I agree. And we're going to be your guides through this dense material, highlighting the key takeaways, clarifying those tricky medical terms, and even exploring some of the real-world applications. So, are you ready to take a deep breath and dive in?
I am.
Great. So the chapter jumps right into infectious lung disorders, and pneumonia is, of course, front and center. It's sadly a bit of a global health superstar.
Yeah, pneumonia is definitely a major player when it comes to respiratory illnesses. And what's really interesting is that it's not just one disease, but a term for inflammation in the lungs caused by a bunch of different invaders. Bacteria, viruses, and even fungi.
Right. And the chapter dives straight into what's called community-acquired pneumonia, or CAP, which is basically pneumonia you pick up out in the world, not in the hospital. But what I thought was interesting is that in most cases of CAP, they never actually figure out which bacteria is causing the problem.
That is a good point. It's one of the challenges of treating pneumonia. With some infections, you can just take a sample and easily identify the culprit. But with CAP, it's more of a guessing game.
Why is that? Are there just too many different bacteria that it could be?
Well, that's definitely part of it. The chapter lists a whole bunch of usual suspects, like Streptococcus pneumonia, Haemophilus influenza, even Staphylococcus aureus. And then you've got atypical bacteria like Mycoplasma pneumonia and viruses like RSV and adenovirus. It's a big group.
It's like a microbial party in there and no one RSVP.
Exactly. And to make it even frickier, each of these pathogens can cause slightly different symptoms.
So if they can't always tell which bacteria is causing CAP, how do doctors even know which antibiotic to use?
They use a combination of clues. They consider the patient's symptoms, their medical history, and even make educated guesses based on what's circulating in the community at the time.
So it's like medical detective work.
Yeah.
And the chapter did mention some telltale signs that can help narrow it down. For instance, if someone is coughing up that rust-colored sputum, that points to Streptococcus pneumonia.
Right. There are certain patterns they look for, but even with those, confirming a diagnosis can be difficult. Even a chest x-ray, which shows those cloudy patches they call infiltrates, basically, areas of inflammation, they don't always tell the whole story.
So diagnosing CAP is kind of piecing together information from a lot of different sources.
It is. And treatment usually starts with broad-spectrum antibiotics, which target a wide range of bacteria while they try to figure out the specific cause.
That makes sense. And of course, the chapter stresses the importance of prevention, especially vaccination. Those pneumococcal vaccines, PCV13 and PPSV23, can really help prevent those serious pneumococcal infections.
Oh, absolutely. Prevention is key.
So let's shift gears a bit and talk about atypical pneumonia. The chapter says that this type often presents more mildly, almost like a stealthy pneumonia, especially in younger and otherwise healthy individuals.
Yeah, that's a good way to put it. Atypical pneumonia can be tricky because those symptoms are often less severe and can mimic other respiratory illnesses like a bad cold or the flu.
The chapter mentions Mycoplasma pneumonia as the most common cause of atypical pneumonia, and it has a unique symptom, bullous myringitis.
Right, which is inflammation of the eardrum. You don't see it with every case, but it can be a clue for doctors.
Fascinating. The chapter also talks about Legionella pneumophila, which I remember reading about. It can spread through contaminated water systems, things like air conditioning units and hot tubs.
Yes, which is why maintaining clean water sources, especially in public places, is so important. And then you've got viral pneumonias. They often start after an upper respiratory infection, which makes them hard to distinguish from a cold at first.
It sounds like diagnosing atypical pneumonia can be just as difficult as CAP, if not more so.
Yeah, you're right. The standard tests, like sputum cultures, aren't always helpful for atypical pneumonia, so doctors really have to rely on the patient's symptoms and their history.
So from the kind of sneaky atypical pneumonia, we go to a more formidable faux hospital-acquired pneumonia, or nosocomial pneumonia.
This is pneumonia that develops after someone's already been admitted to a hospital, usually 48 hours or more after they're admitted. And it's often more serious because the bacteria involved are frequently resistant to common antibiotics.
The chapter says that patients on mechanical ventilation are at the highest risk for this type.
Yeah, and that's because the breathing tube can provide a way for bacteria to get into the lungs. preventing these infections is a big challenge for hospitals, especially for those vulnerable patients.
It's a reminder of how important those infection control measures are: hand washing, sterilization of equipment, and isolation.
Exactly. And the chapter talks about how important it is to act quickly if hospital-acquired pneumonia is suspected. Treatment often involves a combination of potent antibiotics, sometimes delivered intravenously, to try to get ahead of those resistant bacteria.
Okay, let's talk about pneumonia in people with HIV. The chapter says that Streptococcus pneumonia is still a common cause in this group. But there's another culprit that can be especially dangerous in HIV patients, particularly those with low CD4 counts.
You're talking about Pneumocystis jirovecii pneumonia, or PCP. It's actually caused by a fungus, and it can be very dangerous for people with weakened immune systems.
The symptoms sound pretty rough: fever, rapid breathing, difficulty breathing, and a dry cough. It's incredible how a tiny fungus can cause so much trouble.
It is, and it really shows how delicate the balance of the immune system is.
The chapter says that a chest X-ray is crucial for diagnosing PCP. They look for diffuse or bilateral parahilar infiltrates, which are basically those cloudy areas that spread from the center of the lungs.
Right, and they need to start treatment quickly and aggressively, usually with a specific antibiotic called trimethoprim sulfamethoxazole, or Bactrim for short.
The chapter makes it very clear that if they don't treat PCP, it can be fatal, especially in those with advanced HIV. It's a good reminder of how important early detection and treatment are.
Absolutely. And for patients who are at high risk of PCP, the chapter recommends prophylaxis. Basically, they take medication to prevent the infection from happening in the first place.
That's great. Proactive treatment can save lives. Now let's talk about a disease that has been around for centuries: tuberculosis, or TB. It's spread through the air via infected droplets and can be a very sneaky and deadly adversary.
TB is really fascinating from a medical point of view, but it's also a sad reminder of the healthcare inequities that we have around the world.
The chapter explains that TB has two main forms: primary and latent. Primary TB is the initial infection, and it can cause a variety of symptoms: a persistent cough, fatigue, fever, and even coughing up blood.
But sometimes the infection can become latent. It's still there, hiding in the body, but not causing any noticeable symptoms. It's like a dormant volcano just waiting to erupt.
So someone with latent TB might not even know they have it.
That's right, and it's why screening for TB, especially in high-risk groups, is so important.
The chapter talks about the tuberculin skin test, or TST, as a common screening tool. But they also say that the TST has limitations, especially when trying to tell the difference between latent and active infection.
That's why they often use a chest X-ray and sputum cultures to confirm the diagnosis. The chapter actually has a helpful table 2.4 that explains how to interpret the different reactions you might see with the TST.
Oh, nice. Like a cheat sheet for understanding what those skin reactions really mean.
Exactly. And if we're talking about cheat sheets, there's another table that lists all the different anti-tuberculosis medications and their possible side effects. That's table 2.5.
Wow, that's a lot of medications.
Yeah.
And it emphasizes how challenging it can be to treat TB, especially with those drug-resistant strains emerging.
Oh, that's a huge concern. And that's why the chapter talks about directly observed therapy, or DOT. In DOT, a healthcare worker literally watches the patient take their medication every single day.
Wow, that's dedication.
It is, but it helps make sure people are sticking to the treatment plan and reduces the risk of those resistant strains developing.
It's amazing how individual patient care can have such a big impact on public health.
I know.
Wow, we covered a lot about pneumonia and TB.
Yeah.
Let's take a break and we'll come back and tackle some more pulmonary conditions in part 2.
All right, so let's get back to those pulmonary conditions. So we've been talking about some pretty serious infections, but now we're going to switch gears to something many of you have probably experienced: acute bronchitis.
Oh, for sure. I had bronchitis a few years ago, and that cough was no joke. The chapter says that it's usually caused by viruses, which makes sense because it always seems to go around when everyone has colds and the flu.
Yep, viruses are usually the cause. And speaking of viruses, they can also cause acute bronchiolitis, which is a big concern for babies and young children. It's basically inflammation of those tiny airways in the lungs, the bronchioles.
Ah, the poor little ones. I bet that makes it really hard for them to breathe. It says here that RSV, respiratory syncytial virus, is the most common cause. Isn't that a common cold virus in adults?
It is. But in infants, it can be much more serious. They might have a runny nose, sneezing, wheezing, but it can actually progress to pretty serious respiratory distress. Think about it, those tiny airways are already so small, and then when they get inflamed and filled with mucus, it's no wonder they have trouble breathing.
That's awful. What are some of the signs that a baby is having trouble breathing?
Well, you might see their nostrils flaring or the skin between their ribs pulling in with each breath. We call that retractions. I mean, it might even have a bluish tint to their skin, cyanosis, which means the blood isn't getting enough oxygen.
Those are some serious warning signs. It sounds like recognizing it early is crucial.
You got it. Diagnosing bronchiolitis usually just involves a physical exam. Listening to their chests with a stethoscope and maybe checking their blood oxygen levels with a pulse oximeter.
And what about treatment? The chapter talks about supportive care, making sure they're hydrated and getting enough oxygen. Do they use antiviral medications?
Antivirals can be helpful, especially for high-risk infants with RSV, but they aren't always necessary. It really comes down to careful monitoring and just making sure the baby's comfortable and supported.
It makes you realize how fragile those little respiratory systems are. Speaking of fragile, the chapter shifts to a pretty scary condition, acute epiglottitis.
This one is definitely serious, potentially life-threatening even. It's an infection of the epiglottis, which is that little flap of tissue that covers the windpipe when we swallow. You can imagine if that gets swollen and inflamed, it can block the airway.
That's scary. The chapter says it's usually caused by viruses, which is surprising. I always thought epiglottitis was a bacterial infection.
It used to be. But thanks to the Hib vaccine, Haemophilus influenza type B, that was the main bacterial cause, now viral infections are more common.
Wow, vaccines have made a huge difference. The chapter says that kids with epiglottitis often have a sudden high fever, drooling, a muffled voice, and they have trouble breathing and swallowing. But what's interesting is that they usually don't have a cough, which seems kind of counterintuitive.
It is. You would think that with an inflamed airway, coughing would be a major symptom. But that's one of the things that helps doctors tell it apart from other respiratory infections.
So if a child has these symptoms, especially trouble breathing, it sounds like a trip to the ER is in order.
Oh, absolutely. They need medical attention right away. They will need to secure the airway, often in the ICU, and give it antibiotics and corticosteroids to fight the infection and bring down that swelling.
Okay, another childhood illness that can be scary for parents is croup. It's also called acute viral laryngotracheobronchitis, which is a mouthful.
I know, right? It basically means inflammation of the larynx, trachea, and bronchi, those key parts of the airway.
The chapter lists the usual culprits: parainfluenza viruses, RSV, adenovirus, and even influenza. It's like the viral greatest hits. What I remember most about croup is that barking cough, woof woof.
Yes, that's the classic croup cough. They might also have stridor, which is that high-pitched, harsh sound when they breathe in, caused by that narrowed airway.
I've definitely heard that sound before. It says here that on x-rays they might see something called the steeple sign.
Yeah, it's a pretty visual sign. Imagine a church steeple narrowing at the top. That's what the narrowed airway looks like on the x-ray. It helps them confirm the diagnosis and rule out other things.
Okay, so how do they treat croup?
For mild cases, they can usually manage it at home, keep the child calm, offer them fluids, maybe use a cool mist humidifier to make it easier for them to breathe. But for severe cases, or if the child is having real trouble breathing, they might need to go to the hospital.
And what do they do at the hospital?
They might give corticosteroids to reduce the swelling, humidified oxygen, and sometimes even nebulized epinephrine, which opens up the airways very quickly.
Okay, so we talked about some common childhood respiratory infections. Now let's shift to a more serious topic. Neoplastic diseases of the lungs. And when we talk about lung neoplasms, the big one is bronchogenic carcinoma, or lung cancer.
This is definitely a serious topic, and sadly one of the most common and deadliest cancers worldwide. The chapter says that it's the leading cause of cancer death in both men and women.
Those are scary statistics. The chapter talks about different types of lung cancer and starts with two main categories: small cell lung cancer, or SCLC, and non-small cell lung cancer, or NSCLC.
Right, and that's a really important distinction because it changes how they stage and treat the cancer. SCLC is known for being very aggressive. It usually starts in the central airways, the bronchi, and spreads to other parts of the body pretty quickly.
So it's a fast-moving cancer that spreads easily.
That's it. And because of that, treatment usually involves systemic therapies like chemotherapy and radiation instead of surgery. Surgery often isn't an option because by the time they find it, it's already spread too far.
NSCLC seems to be a little more varied, though.
Yeah, there are several subtypes. The chapter mentions squamous cell carcinoma. This one often starts in the central airways, and sometimes they find it through cytology, where they look at the cells in the sputum, that stuff you cough up.
Wait, so they can actually see cancer cells under a microscope just from a sputum sample?
Sometimes, yeah. It's not always the case, but it can be really useful. Then you've got adenocarcinoma. It tends to grow in the outer parts of the lungs, and they usually diagnose this one with a biopsy taken during a bronchoscopy.
I've heard of bronchoscopy. What exactly is that?
It's a procedure where they put a thin, flexible tube with a camera on the end down your throat and into the airways. It lets doctors see the lungs, take biopsies, even remove small obstructions.
Sounds a bit intense, but I can see how useful it would be.
It really is. And then the last subtype is large cell carcinoma. It's less common than the other types of NSCLC, but it tends to grow and spread quickly, which means that early diagnosis and treatment are super important.
It sounds like staging, figuring out how far the cancer has spread, plays a big role in determining the treatment options.
Huge role. The chapter says that for NSCLC, treatment usually involves surgery, if they can do it, to remove the tumor, and then chemo or radiation after that.
Okay, so let's talk about the symptoms of lung cancer. The chapter lists a few that seem pretty general. A new or changing cough, coughing up blood, chest pain, not feeling hungry, losing weight. Are those the only signs?
Those are the common ones, but lung cancer can also have more subtle symptoms. You might see swollen lymph nodes, an enlarged liver, even something called clubbing of the fingers, where the fingertips get round and bulbous.
Clubbing of the fingers, that's a new one. What does it have to do with lung cancer?
We don't know for sure, but it seems to be related to changes in blood flow and oxygen levels in the body.
That is really interesting. The chapter also mentions something called paraneoplastic syndromes.
Oh, yeah. These are syndromes caused by substances that the tumor releases that then affect other parts of the body. It's crazy. Sometimes seemingly unrelated organs are affected. For example, some lung cancers can cause hormonal imbalances, neurological problems, or even blood clotting disorders.
So it's not just the tumor itself that causes problems, but the tumor can have these ripple effects throughout the body.
Exactly. And sometimes these syndromes are actually the first sign that something's wrong, even before the classic lung cancer symptoms show up.
Okay, how do they diagnose lung cancer? The chapter mentions a whole bunch of tools: chest x-rays, CT scans, sputum cytology, bronchoscopy, even PET scans.
It's like they're conducting a high-tech investigation to figure out exactly where the tumor is, how big it is, and how far it's spread.
And of course, they need to do a biopsy, take a sample of the tissue to confirm the diagnosis and see what type of cancer it is.
Absolutely. They might also do molecular testing to look for certain mutations in the cancer cells.
Oh, right, I've heard about those targeted therapies. They use medications that attack specific weaknesses in the cancer cells.
That's it. They can use those tests to figure out which therapies are most likely to be effective for that particular type of cancer, so they have a better chance of success and fewer side effects.
It's amazing how far we've come with personalized cancer treatment. The chapter also talks about some of the complications of lung cancer, things like SVC syndrome and Horner syndrome. Those sound pretty bad.
They can be, for sure. SVC syndrome, superior vena cava syndrome, happens when the tumor presses on the superior vena cava, a major vein that carries blood from the head and upper body back to the heart. It can cause swelling in the face, neck, and arms, and even trouble breathing. And Horner syndrome, that one affects the nerves that control the face and eye, causing symptoms like a drooping eyelid, a constricted pupil, and less sweating on one side of the face.
So lung cancer can really have effects far beyond the lungs themselves.
It can, and that's why it's so important to have a team of specialists involved in treatment. Oncologists, surgeons, pulmonologists, all working together.
All right, let's move on to something a little less scary: solitary pulmonary nodule, or SPN. It sounds kind of lonely.
It does, but even though it sounds harmless, an SPN can cause a lot of anxiety. It could be a harmless scar, or it could be early lung cancer.
It's basically what they call a coin lesion, a round or oval spot they see on a chest x-ray that's less than 3 centimeters across. It's interesting, the chapter says most of the time they find these SPNs by accident when they're doing imaging for a totally different reason.
It's true. And it shows why regular checkups and imaging are so important, especially for people who are at higher risk for lung cancer, like smokers.
The chapter has a great table 229 that outlines the differences between benign and malignant nodules and how to manage each.
It's really helpful for understanding how they make decisions about these nodules. Benign nodules usually have smooth margins, and they grow slowly if they grow at all. And sometimes the doctors just watch them over time, doing CT scans periodically to make sure they're not changing. Malignant nodules, on the other hand, usually have irregular margins and grow faster.
So the size, shape, and growth rate all give clues.
Yeah.
But what happens if they can't tell for sure just from the imaging?
That's when they need to do a biopsy to get a definite answer. They might use a needle biopsy, where they put a needle through the chest wall to get a sample, or they might do a bronchoscopy to get a biopsy from the inside.
The chapter says that the patient's risk factors, like their age, whether they smoke, and if they've been exposed to environmental toxins, all play a role in deciding what to do about an SPN.
It's a perfect example of how they personalize medicine, considering the individual patient's situation when choosing a treatment.
Okay, let's talk about another type of lung tumor, carcinoid tumors. I have to admit, I'm not familiar with these.
They're pretty rare, actually, much less common than lung cancer. They're neuroendocrine tumors, meaning they start in the cells that produce hormones. And usually they're less aggressive than lung cancers. They tend to grow slowly.
And what kind of symptoms do they cause?
A lot of times they don't cause any symptoms at all, but sometimes they can cause coughing up blood, a cough that just won't go away, or wheezing in one specific area of the lung.
The chapter also mentions something called carcinoid syndrome, which sounds pretty intense.
Yeah, that's a bunch of symptoms together, like flushing, diarrhea, wheezing, and even low blood pressure. It's actually caused by the hormones that the tumor releases.
So it's like the tumor is messing with the body's hormones.
That's right. It's a good example of how interconnected all the systems in the body are, and how a tumor in one spot can affect things somewhere else entirely.
How do they diagnose and treat carcinoid tumors?
They often use a bronchoscopy to see the tumor. It usually looks like a pink or purple lump in the middle of the airway. They also use CT scans and sometimes a special type of imaging called octreotide scintigraphy, which highlights neuroendocrine cells. They use those to figure out where the tumor is and how big it is.
What about treatment?
Surgery is the best option for carcinoid tumors. It gives the best chance of a cure. And if someone has carcinoid syndrome, there's a medication called octreotide that can help manage the symptoms by blocking the release of those hormones that are causing the problems.
Okay, let's move on to a group of lung diseases that a lot of people are familiar with, obstructive pulmonary diseases. And the first one that comes to mind is asthma.
Asthma is so common. Millions of people around the world have it. And it's one of those conditions that a lot of people don't really understand, partly because it can look so different in different people.
The chapter emphasizes the three main features of asthma: airflow obstruction, meaning it's harder to breathe out; bronchial hyperreactivity, where the airways overreact to triggers; and inflammation, which narrows the airways. It's like a triple threat to the lungs.
It is. And the things that trigger asthma are all over the place. Allergens like pollen and dust mites, irritants like smoke and cold air, even exercise and stress can trigger an asthma attack.
Yeah, the chapter has this big table, Table 210, listing all kinds of potential triggers: pet dander, mold, even aspirin.
It's mind-boggling, and it's one reason why it's so important to figure out a person's individual triggers so they can avoid them as much as possible.
So what are the signs of an asthma attack?
Wheezing, that whistling sound when you breathe, is the classic symptom. But you also might hear coughing, especially at night or early in the morning, and shortness of breath, that feeling of not being able to get enough air.
But it says here that not everyone with asthma wheezes. That's surprising.
It is, especially in little kids. Sometimes their symptoms are more subtle, like just a nagging cough or getting out of breath easily when they're playing.
That makes it even harder to diagnose.
Right, well, for sure. That's why they look at the whole picture: the patient's symptoms, their medical history, and they use a test called spirometry.
I've heard of spirometry, but what is it exactly?
It's a test that measures how much air you can breathe in and out and how fast you can do it. It helps figure out if there's an obstruction in the airflow and how bad it is.
So it's like a test for how well your lungs are working.
Yeah, exactly. And for asthma, they usually do a bronchodilator test along with the spirometry.
What's that?
So you breathe in this medication that opens up the airways, a bronchodilator, and then they repeat the spirometry test. If your lung function gets a lot better after the bronchodilator, it's a good sign that you have asthma.
Makes sense. So how do they treat asthma? There's so many different types of inhalers out there.
There are, and the chapter describes a stepwise approach to treatment depending on how severe the asthma is. Quick relief inhalers, they call them rescue inhalers too, have medications like short-acting beta agonists or SABAs that relax the muscles around the airways. Those provide quick relief during an attack.
So those are the ones you use when you feel that tightness in your chest and can't catch your breath.
Exactly. They're like your first line of defense. And for people who have asthma more often, they use what the chapter calls long-term controllers. These are often inhaled corticosteroids that work by reducing the inflammation in the airways. That helps prevent those attacks from happening in the first place.
So it's kind of a two-pronged approach. Quick relief when you need it, and long-term treatment to manage the condition.
Exactly. And the chapter really stresses that patients need to be educated about their condition. They need to understand their triggers, use their meds correctly, and even monitor their lung function at home with a peak flow meter.
A peak flow meter. What is that? Something out of Star Trek.
Not quite. It's actually a really simple handheld device that measures how forcefully you can breathe out. It helps track your lung function over time so you know if things are getting worse.
Hmm.
It can even warn you about an attack before it happens.
Wow, that's amazing. Like having a little lung monitor you can carry with you.
Right. It lets people with asthma manage their condition themselves and be proactive about their health.
Okay, let's talk about another obstructive lung disease, bronchiectasis. I don't know much about this one. What is it exactly?
So with bronchiectasis, the bronchi, those airways in your lungs, become damaged and widened. Imagine them like balloons that have been stretched out. And those stretched out areas create little pockets where mucus gets trapped and bacteria can grow.
Yuck, so it's like having these little pools of infection in your lungs.
Pretty much. And that's why the main symptom is a chronic productive cough, one that produces phlegm. The phlegm is usually thick, discolored, and sometimes it even has a bad smell because of those bacteria hanging out in there.
Sounds delightful. It says here that bronchiectasis can be congenital, meaning you're born with it, or acquired. What are the common causes of the acquired kind?
Recurrent infections, especially in childhood, are a big one. If they don't treat those lung infections properly, they can damage the airways, and that can lead to bronchiectasis later on.
So it's like the after effect of those repeated infections. The chapter also says airway obstructions can cause it. What kind of obstructions?
It could be anything that's blocking the airway, like a tumor, a foreign object that's been inhaled, or even thick mucus plugs in conditions like cystic fibrosis, which we'll talk about later.
All right, so if someone has bronchiectasis, how do they diagnose it and how do they treat it?
They use high-resolution CT scans to diagnose it. Those scans give them a really detailed picture of the airways, and they can see those dilated and distorted bronchi.
Those scans sound impressive. What about treatment?
The main focus of treatment is managing that cough and preventing infections. They often recommend chest physiotherapy, which uses different techniques to help loosen up and clear out the mucus. And of course, they use antibiotics to treat those bacterial infections that love to grow in those mucus-filled pockets.
And the chapter mentions surgery as an option, but it sounds like that's not very common.
Right. They usually only consider surgery if the bronchiectasis is limited to a small area of the lung and nothing else has worked.
Okay, now on to another big one when it comes to obstructive lung disease. Chronic obstructive pulmonary disease, or COPD. I feel like I hear about COPD all the time, but I'm not sure I really understand what it is.
So COPD is actually a term that includes two conditions, emphysema and chronic bronchitis. And a lot of times, people have features of both, which can make it harder to diagnose and treat.
That makes sense. The chapter describes emphysema as damage to the alveoli, those tiny air sacs in the lungs. That damage makes it difficult to breathe.
Imagine those tiny air sacs, you know, the ones that are responsible for exchanging oxygen and carbon dioxide? Well, in emphysema, they become all stretched out and lose their elasticity. It's like trying to blow up a balloon that's lost its stretch. It's harder to inflate and doesn't hold as much air.
And chronic bronchitis is basically long-term inflammation and mucus production in the airways.
You got it. Those airways get irritated and swollen, and they produce too much mucus, leading to that chronic cough and difficulty breathing.
It has this table, Table 212, that compares the classic patient types. It calls them pink puffers, those with mostly emphysema, and blue bloaters, those with mostly chronic bronchitis. Those are colorful names.
I know, right? So the pink puffers tend to be thin, breathe heavily, and don't cough very much. The blue bloaters often have a chronic cough, lots of phlegm, and may even have a bluish tint to their skin, that cyanosis we talked about before, because their blood oxygen level is low.
Okay, so what causes the lung damage that leads to COPD?
Smoking. Without a doubt, smoking is the main cause. All those chemicals in cigarette smoke irritate and inflame the airways, and over time they destroy those little air sacs.
It's hard to believe people still smoke when you think about the damage it does. But are there other things that can contribute to COPD besides smoking?
Yeah, there are. Environmental pollutants, like air pollution and dust in the workplace, can also play a role. And there's a genetic condition called alpha-1 antitrypsin deficiency that can cause emphysema to develop early on.
So it's not always just about smoking.
Nope. And unfortunately, COPD is progressive. It means that the damage to the lungs just keeps getting worse over time. There's no going back.
What are the usual symptoms?
The main one is shortness of breath, especially when you exert yourself. As the disease progresses, even easy activities like walking or going upstairs can become really difficult. And that chronic cough, often with phlegm, is another common symptom, especially for those with more of the chronic bronchitis type.
And what would a doctor look for during a physical exam?
They might notice the patient breathing through pursed lips. That's a technique that helps keep the airways open. And often they develop what we call a barrel chest. That's where the chest becomes rounded because of air trapping. When they listen to the lungs, they might hear decreased breath sounds and wheezing.
Okay, so how do they diagnose COPD?
Spirometry is the key test here. It measures airflow and can show that characteristic obstruction. They'll also look for something called a decreased FEV1-FVC ratio, which means the amount of air you can forcefully exhale in 1 second is much lower than your total lung capacity.
That sounds a bit technical.
Okay, imagine you try to blow out all the air in your lungs as fast as you can. That's your forced vital capacity, or FVC. Now, imagine blowing out as much air as you can, but just for 1 second, that's your FEV1. In COPD, that 1 second burst is much smaller compared to how much your lungs can actually hold because the airways are narrowed, making it hard to get the air out quickly.
Okay, I think I get it. The chapter also says they might check a complete blood count, or CBC. What are they looking for there?
They might see an increased number of red blood cells, a condition called polycythemia. It's often seen in folks with chronic hypoxemia, which means low blood oxygen levels. It's basically the body trying to make up for the lack of oxygen by making more red blood cells to carry oxygen throughout the body.
Wow, the body is pretty amazing at adapting.
It really is. Speaking of adapting, let's talk about managing COPD. I'm guessing quitting smoking is the most important thing, right?
It's gotta be. But what about people who've already quit or never smoked? What can they do?
Well, there are a lot of strategies for managing the disease. Inhaled bronchodilators, both short-acting and long-acting, can help relax the muscles around the airways, making it easier to breathe.
So those are the inhalers people with COPD use.
Yep, exactly. They come in different types, metered dose inhalers, dry powder inhalers, but they all deliver medication directly to the lungs where it's needed.
What else? Any other treatments?
Sometimes they use oral corticosteroids for acute exacerbations, those times when the symptoms suddenly get a lot worse. That's often triggered by an infection or exposure to irritants.
So they help reduce inflammation fast.
That's right. But if you use oral corticosteroids for too long, they can have some bad side effects, so they're usually just used for short periods.
The chapter also talks about supplemental oxygen therapy.
Yeah, that's super important for people whose blood oxygen is low, even when they're resting. It can improve their quality of life a lot and even help them live longer.
It's amazing how much of a difference just getting enough oxygen can make.
I know, right? And there are other things that help too. Pulmonary rehabilitation, for example. It combines exercise, education, and breathing techniques to help people with COPD manage their symptoms and have a better quality of life.
It's like a whole body approach to managing a chronic lung condition.
Exactly. The chapter also mentions alpha-1 antitrypsin replacement therapy for people with that genetic condition.
Can you remind me what that is again?
Sure. It's that genetic thing we talked about earlier that can cause emphysema to develop early. People with this deficiency don't make enough of a protein called alpha-1 antitrypsin that protects the lungs from damage. So with this therapy, they get infusions of that protein to try and slow down the lung damage.
It's amazing. It's like they're giving their body back a missing piece.
I know, right? And of course, for folks with COPD, it's super important to stay up to date on their vaccinations, especially for influenza and pneumococcal pneumonia. Infections can be really dangerous for them.
Okay, we covered a lot about COPD. What about cystic fibrosis? I know it's a lung disease, but how does it work exactly?
Cystic fibrosis is a genetic disorder that affects the cells that make mucus, sweat, and digestive juices. Basically, it causes those secretions to become thick and sticky, which then clogs up different organs, especially the lungs and the pancreas.
The chapter says it's an autosomal recessive disorder, meaning both parents have to carry the gene for their child to have the condition.
That's right. And it's a serious disease. The average life expectancy is only about 31 years. But with better treatments and management, more and more people with CF are living longer, healthier lives.
What are the main symptoms?
The most obvious ones are respiratory, a chronic cough, producing lots of phlegm, and frequent lung infections. Imagine those thick, sticky secretions clogging up the airways. It's the perfect breeding ground for bacteria.
It sounds like a constant battle against infection.
It is. And that's why a lot of the treatment focuses on clearing those airways and trying to prevent infections.
Are there any other symptoms besides the respiratory ones?
Yeah, because that thick mucus can also affect the pancreas and makes it hard to digest food and absorb nutrients. So they might not gain weight well, their poop might be bulky, and they could have belly pain.
Wow, so it affects more than just the lungs. When do they usually diagnose cystic fibrosis?
Often in infancy or early childhood, they usually diagnose it based on the symptoms, a sweat test, and genetic testing.
A sweat test? What's that all about?
It's a pretty simple test. They measure the amount of salt in the sweat. People with cystic fibrosis have really high salt levels in their sweat because of a problem with the protein that controls salt and water transport in the body.
So it's a good indicator of CF.
It is. And then genetic testing can actually confirm the diagnosis because it identifies the specific mutations in the CFTR gene that cause the disease.
Okay, so how do they manage cystic fibrosis?
It's a multi-pronged approach. Airway clearance techniques to get rid of the mucus, medications to thin the mucus and open up the airways, antibiotics to treat those infections that keep coming back, pancreatic enzyme supplements to help with digestion, and nutritional support to make sure they're getting enough calories and nutrients.
Sounds like a whole team of people is involved. Pulmonologists, gastroenterologists, nutritionists, and who knows who else.
You're telling me. But thankfully, with better treatments and care, things are looking up for folks with cystic fibrosis. Their outlook keeps getting better.
Okay, let's talk about pleural diseases now. I have to admit, I'm not really familiar with what the pleura is.
So the pleura is a thin membrane that lines the chest cavity and surrounds the lungs. Picture it like a sack with two layers. One layer lines the chest wall and the other covers the lungs. The space between those layers, the pleural space, usually has just a tiny bit of fluid that acts like a lubricant and helps the lungs move smoothly when you breathe.
So it's like a cushion for the lungs.
That's a good way to think about it. And when things go wrong with the pleura, it can cause all sorts of breathing problems.
The first pleural disease the chapter talks about is pleural effusion. Basically, that's when fluid builds up in that space around the lungs.
Right. That space between those two layers, where there's usually just a little bit of fluid, starts filling up like a water balloon. And where that fluid comes from depends on what's causing the effusion in the first place.
So what are some of the common causes?
Inflammation is a big one. Things like pneumonia, rheumatoid arthritis, even lupus, those can cause inflammation in the pleura and lead to fluid building up.
So the inflammation is spilling over into that space.
Exactly. Infections can also cause effusions, and so can heart failure, where the heart's not pumping effectively and fluid backs up into the lungs and the tissues around them.
The chapter also mentions transudative effusions.
Those are caused by changes in pressure within the blood vessels. It basically forces fluid out into the surrounding tissues. Think of it like a leaky faucet.
Okay, so let's say someone has a pleural effusion. What kind of symptoms would they have?
It really depends on how much fluid has built up. Small effusions sometimes don't cause any symptoms at all, and they might just find it by accident on an x-ray or something. But when more fluid builds up, it starts to squish the lung, making it hard to breathe.
So shortness of breath would be a common symptom.
Definitely. And it might be worse when they lie down. We call that orthopnea. That's because gravity pulls more fluid towards the lungs when you're lying flat. They might also have chest pain, especially when they take a deep breath. That's because the inflamed pleura is rubbing against the chest wall.
Okay, so how do they diagnose and treat pleural effusions?
Chest x-rays are usually the first thing they do. They can show that characteristic blunting of the costophrenic angle.
The costophrenic angle, what's that?
So that's the angle where the diaphragm, the big muscle that helps us breathe, meets the ribs. Normally it's a sharp angle, but when you have a pleural effusion, it gets kind of blunted or rounded because the fluid is filling up that space.
Okay, that makes sense. So an x-ray can give them a clue, but what if they need more information?
Then they might do a CT scan. It gives them a clearer picture of what's going on in the chest and helps them see if the fluid is free-flowing or if it's trapped in pockets.
And they might do a thoracentesis.
Right. Thoracentesis is when they put a needle into the chest cavity and actually take out some of the fluid. They can look at the fluid under a microscope to see what's going on, and they also drain the fluid to make it easier for the patient to breathe.
So it's a 2-for-1, diagnosis and treatment.
You got it.
Yeah.
And the chapter has this handy table, table 213, that describes something called Light's criteria.
Light's criteria, huh? What is that?
It's basically a set of rules that helps them figure out what kind of pleural effusion it is. Is it a transudative effusion caused by pressure changes like in heart failure, or is it exudative caused by inflammation or infection? Knowing what kind it is really helps them decide the best way to treat it.
So it's like a fluid fingerprint.
Exactly. And the treatment for a pleural effusion depends on what's causing it in the first place. If it's from an infection, they'll treat the infection with antibiotics. If it's from heart failure, they'll focus on treating the heart failure. And sometimes they might need to drain the fluid over and over, or even do a procedure called pleurodesis.
Pleurodesis, that
Yeah.
sounds serious.
It is. It's when they intentionally irritate the pleura to make those two layers stick together. That way fluid can't build up in that space anymore.
Like sealing up a leaky pipe.
Yeah.
Okay, let's switch gears to another pleural condition that can be really scary, pneumothorax. It's basically a collapsed lung, right?
That's right. Remember we were talking about that double-layered sac, the pleura? Well, a pneumothorax happens when air gets into the space between those layers, the pleural space, and that air presses on the lung, causing it to collapse, either part of it or the whole thing.
Like a balloon that sprung a leak.
Perfect analogy. And there are a few ways that air can get in there. Sometimes it happens spontaneously for no apparent reason. It often happens in young guys who are tall and thin. Other times it's caused by an injury to the chest, like a broken rib or a stab wound. That creates a hole in the chest wall and air rushes in.
The chapter also says pneumothorax can be iatrogenic.
Yep, that means it's caused by a medical procedure. Some procedures they do on the chest, like biopsies or surgery, carry a small risk of causing a pneumothorax.
Okay, so let's say someone has a pneumothorax. What kind of symptoms would they have?
Usually they have this sudden, sharp chest pain on the side where the lung is collapsed. And as the lung collapses, it gets harder and harder to breathe, so shortness of breath is another big symptom.
So it sounds like the symptoms are pretty obvious.
They can be. When a doctor examines someone with a pneumothorax, they might hear less breath sounds over the collapsed area because the lung isn't moving as much. They might also notice what we call a hyperresonant percussion note. It means that when they tap on the chest over the pneumothorax, it sounds kind of hollow because of all that air trapped in there.
Like tapping on a drum.
Exactly. And usually they confirm the diagnosis with a chest x-ray. It'll clearly show that air pocket pushing on the lung.
So how do they treat it?
It depends on how big the pneumothorax is and how bad the symptoms are. If it's a small pneumothorax, they might just watch the patient and wait for it to resolve on its own. The air is slowly reabsorbed back into the body.
So they just wait for the balloon to reinflate.
Pretty much. But if it's a big pneumothorax or if it's causing a lot of problems, they have to do something to get that air out and let the lung re-expand.
Right, the chapter mentions chest tubes.
Right. So a chest tube is a small tube they put into the chest cavity to drain the air. They connect it to a suction device that gently sucks the air out and helps the lung reinflate.
And then there's tension pneumothorax, which the chapter says is life-threatening. Oh yeah, tension pneumothorax is a real emergency. It happens when air gets trapped in the pleural space and can't get out. It creates a one-way valve kind of situation.
So more and more air gets trapped in that space, putting more pressure on the lung and the heart.
Exactly. And that pressure gets so bad that it can actually start to shift the heart and other structures in the chest over to the other side. That makes it really hard for the heart to pump blood effectively.
That sounds terrifying. So how do they treat that?
They have to act fast. They have to get that trapped air out ASAP, and they do that by putting a big needle into the chest cavity. We call that needle thoracostomy. It creates an escape route for the trapped air, which stabilizes the patient while they get ready to do something more permanent, like putting in a chest tube.
Okay, so that's pneumothorax. Now let's move on to pulmonary circulation disorders, which, for me, always makes me think about blood clots. You're right on the money. Pulmonary embolism, or PE, is when a blood clot, usually one that forms in the deep veins of the legs, travels to the lungs and blocks an artery there, cutting off blood flow.
The chapter says that PE is the third leading cause of death in hospitalized patients. That's scary.
It is, and it just shows how important it is to understand what increases your risk for blood clots and to try to prevent them, especially if you're in the hospital where people are often immobile and at higher risk.
So what are some of those risk factors?
Well, the chapter mentions something called Virchow's triad. It describes the three main things that can lead to a blood clot forming. Venous stasis, which means slow blood flow, often from not moving around enough, vascular injury, like damage to a blood vessel from surgery or trauma, And hypercoagulability, meaning the blood is more likely to clot, maybe because of genes or some other medical condition.
So it's like the perfect recipe for a blood clot, sluggish blood flow, a damaged blood vessel, and blood that's already prone to clotting.
That's a great way to put it. And it's really important to remember that a lot of people with PE don't have any symptoms at all. That makes it really hard to diagnose.
But the chapter does mention that classic triad of symptoms: pleuritic chest pain, shortness of breath, and a feeling of doom.
Yeah, those are the textbook signs, but other things can happen too, like coughing up blood, sweating, and even a really fast heart rate.
So the way it presents can be pretty different from person to person.
It really can, and that's why it's so hard to diagnose. Doctors have to put together all the pieces of the puzzle, the symptoms, the risk factors, and the results of different tests.
So what kind of tests do they use to diagnose PE?
The gold standard is a CT pulmonary angiogram, or CTPA. It's a special kind of CT scan that uses contrast dye to see the blood vessels in the lungs. It can really clearly show if there's a blockage.
And I remember the chapter also mentions a D-dimer blood test and a ventilation perfusion scan.
Right, so the D-dimer test measures a substance that's released when a blood clot breaks down. So if the D-dimer is high, it can be a clue that there's a clot somewhere. But it's not foolproof because other things can cause a high D-dimer too. And the VQ scan uses these radioactive tracers to look at the airflow and blood flow in the lungs. Sometimes that can hint at a PE, but it's not as clear-cut as the CTPA.
Okay, so what happens if someone is diagnosed with a PE? What's the treatment?
The main treatment is anticoagulation, or blood thinners. These meds help prevent the clot from getting bigger, and they lower the chances of new clots forming.
So it's like they're making the blood less sticky.
Yep, that's a good way to think about it. And there are a lot of different blood thinners out there. There's heparin, which they give by injection and which acts very quickly. And then there are pills like warfarin and some newer ones like rivaroxaban and apixaban.
The chapter also mentions thrombolysis. That's like a clot-busting medication. Right. When would they use that?
They only use thrombolysis in severe cases when the clot is large and causing a lot of problems. It's a more risky treatment because it can cause bleeding.
And what about that vena cava filter? That sounds kind of like a strainer that catches blood clots.
It is, sort of. It's this little cage-like device that they put into the inferior vena cava, which is the big vein that carries blood from the lower body back to the heart. So if a clot breaks loose from the legs, the filter catches it before it can get to the lungs.
Wow, that's super clever.
It is. But the best way to deal with PE is to prevent it in the first place. That means getting up and moving around as soon as possible after surgery or illness. That helps keep the blood flowing and makes it less likely to clot.
And the chapter mentions compression stockings, too, those tight stockings that people wear in the hospital.
Those are great for helping the blood flow in the legs and preventing clots. And sometimes doctors will even recommend prophylactic anticoagulation, which means taking blood thinners to prevent clots, even if you haven't had one yet. They do that for folks who are at high risk, like those having certain types of surgery or who have a history of blood clots.
Okay, let's talk about another pulmonary circulation disorder: pulmonary hypertension. What is that exactly?
Pulmonary hypertension is basically high blood pressure in the pulmonary arteries, the blood vessels that carry blood from the heart to the lungs.
So it's like regular high blood pressure, but in the lungs.
Yeah, you got it. And just like regular high blood pressure can damage your heart and other organs, pulmonary hypertension can damage the right side of the heart. Over time, it can lead to right-sided heart failure.
The chapter says there are two main types of pulmonary hypertension: primary and secondary.
So primary pulmonary hypertension, which is sometimes called idiopathic pulmonary hypertension, is really rare and very serious. And we don't really know what causes it. It's like the body's own immune system is attacking the pulmonary arteries, causing them to narrow and thicken, which restricts blood flow. Secondary pulmonary hypertension is more common, and it's caused by some other underlying condition, like lung disease, heart disease, or even some connective tissue disorders.
So it's like something else is wrong, and then that causes problems in the pulmonary arteries.
Exactly. And it's tricky because the symptoms of pulmonary hypertension can be really vague.
Like what kind of symptoms should people look out for?
The most common early symptom is shortness of breath, especially when they exert themselves. As it gets worse, they might feel tired all the time, have chest pain, even faint, especially when they're active. And if the right side of the heart starts to fail, they might have swelling in their legs and ankles, which means fluid is building up.
Okay, so how do they figure out if someone has pulmonary hypertension?
Usually the first test they do is an echocardiogram, which is an ultrasound of the heart. That can show if the right side of the heart is bigger than it should be, or if there's something wrong with the valves. But the best test is a right heart catheterization. That's a procedure where they put a thin tube into a vein and thread it all the way up to the heart to actually measure the pressure in the pulmonary arteries.
Sounds a bit intense.
It is an invasive procedure, but it gives them the most accurate information about how severe the pulmonary hypertension is.
So how do they treat it?
It depends on whether it's primary or secondary. If it's primary pulmonary hypertension, there are meds that can help open up the pulmonary arteries, which lowers the pressure and improves blood flow. These include things like calcium channel blockers, prostacyclin analogs, endothelin receptor antagonists, and phosphodiesterase inhibitors, lots of long names.
It sounds complicated.
It can be, and if it's secondary pulmonary hypertension, the most important thing is to treat the underlying condition that's causing it. So if it's lung disease, they treat the lung disease. If it's heart disease, they treat the heart disease. You get the idea.
Makes sense. And in really severe cases, they might do a lung transplant.
That's right. If it's primary pulmonary hypertension that doesn't get better with meds, or if someone has end-stage lung disease that's causing the pulmonary hypertension, a lung transplant might be the only option.
All right, let's move on to the last category of lung conditions in this chapter, restrictive lung diseases. What does restrictive mean exactly?
Restrictive lung diseases are diseases that make it hard for the lungs to fully expand. That means you can't breathe in as much air, and it makes it hard to breathe. It's like trying to blow up a balloon that's too stiff to inflate all the way.
The first one they talk about is idiopathic pulmonary fibrosis, or IPF. What does idiopathic mean again?
It means they don't know what causes it. So basically, with IPF, the lung tissue gets all scarred up, which makes it stiff and inflexible. But we don't know what triggers the scarring process to start in the first place.
And the chapter says that IPF is the most common type of interstitial lung disease. What's that?
Interstitial lung disease is a whole group of lung diseases that affect the interstitium, which is the tissue and the space around the air sacs of the lungs. It's like the scaffolding that holds the lungs together. When the interstitium gets inflamed and scarred, it can make it really hard for the lungs to expand and contract the way they should.
So it's like the support structure of the lungs is falling apart.
Yeah, exactly. And IPF is just one kind of interstitial lung disease, but it's one of the most common and also one of the most serious.
So what are the symptoms?
The main one is shortness of breath that gets worse over time, especially when they exert themselves. It's like they can't catch their breath, and it gets harder and harder to do even simple things.
And what would you see on a physical exam?
Often you can hear crackling sounds in the lungs, called crackles, when you listen with a stethoscope. And they might have clubbing of the fingers. Remember those bulbous fingertips?
Yeah, I remember. So how do they diagnose IPF?
High-resolution CT scans are key because they can show that characteristic scarring pattern in the lungs. And pulmonary function tests will show that restrictive pattern. The lung volumes are decreased, but the FEV1 FVC ratio is normal or even high.
Wait, so even though it's hard to get air in, they can still blow it out quickly?
Exactly, because their airways aren't blocked, and sometimes they might do a lung biopsy to confirm the diagnosis.
What about treatment? Is there a cure?
Unfortunately, there's no cure for IPF. The treatments they have now just try to slow down how fast it gets worse and help manage the symptoms. There are a few medications that can help with the inflammation and scarring, but they don't really reverse the damage that's already been done.
So it's about slowing the decline and keeping people comfortable.
Exactly. And supportive care, things like oxygen therapy and pulmonary rehabilitation, can make a big difference. In some cases, they might do a lung transplant, but that's obviously a big deal with a lot of risks and potential complications.
Okay, let's move on to another group of restrictive lung diseases. The pneumoconioses. I vaguely remember learning about these in school, something about coal miners getting black lung.
Yeah, you're on the right track. So pneumoconioses are a group of lung diseases caused by breathing in certain dusts.
So it's like an occupational hazard.
It can be. The type of pneumoconiosis you get depends on the kind of dust you breathe in. Coal workers' pneumoconiosis, or black lung, is from breathing in coal dust. Asbestosis is from breathing in asbestos fibers. Silicosis is from silica dust. There are others too.
The chapter has this table, Table 214, that lists the different types of pneumoconiosis and what kind of jobs are at risk and what the x-rays look like for each one.
It's a great resource. For example, with asbestosis, you often see what they call pleural plaques, which are these areas of thickening on the lining of the lungs. And silicosis usually shows up as lots of little round nodules scattered throughout the lungs.
So each dust leaves its own unique mark on the lungs.
It does. That's why it's so important for doctors to ask about a patient's work history when they're trying to figure out what's wrong.
What are the symptoms of these conditions?
In the early stages, they might not have any symptoms at all. But as they breathe in more and more dust and the scarring gets worse, they might start to have shortness of breath, cough, and chest tightness. And there can be complications too, like progressive massive fibrosis, where large areas of the lungs get all scarred up. And some of them, especially asbestosis, increase the risk of lung cancer.
That sounds pretty serious. What do they do to treat it?
Unfortunately, there's no cure for pneumoconiosis. The best thing is to prevent them in the first place. Make sure workplaces are safe and people aren't exposed to those dangerous dusts. Things like wearing masks and having good ventilation systems can really help.
So workplace safety is key. But what about people who already have one of these conditions?
For them, the treatment focuses on managing the symptoms and preventing more damage to the lungs. They might use oxygen therapy, pulmonary rehabilitation, and medications to help them breathe better and control inflammation.
And no smoking, of course.
Right. Smoking just makes everything worse. It damages the lungs even more and makes them more likely to have complications.
Okay, last condition in this section, sarcoidosis. What is that one?
Sarcoidosis is a bit of a mystery. It's what we call a multi-system granulomatous disease, meaning it causes these little clusters of inflammatory cells called granulomas to form in different organs in the body. It usually affects the lungs the most, but it can also involve the lymph nodes, skin, eyes, really any organ.
Because it's like this inflammation that can pop up anywhere.
Yeah, pretty much. And we're not really sure what causes it, but we think it's an autoimmune thing where the body's own immune system is attacking its own tissues. We think there might be some environmental trigger that sets it off, but we don't know what it is yet.
So the symptoms must be all over the place, depending on what organs are involved.
You got it. People who have lung involvement might have a cough, shortness of breath, chest discomfort. They might also have more general symptoms like fatigue, fever, weight loss, things like that.
And what about those extrapulmonary symptoms, the ones that happen outside the lungs?
They can be all sorts of things. One of the classic signs is erythema nodosum, which is these painful red bumps, usually on the shins. They might have enlargement of the parotid glands, those are the salivary glands in the cheeks, and even eye involvement like uveitis, inflammation in the eye. It can be a real mixed bag.
So how do they diagnose it if the symptoms could be so different?
They look at the whole picture, the patient's symptoms, imaging studies like chest x-rays and CT scans, blood tests, and sometimes they even do a biopsy to actually look for those granulomas under the microscope.
And how do they treat it?
Corticosteroids, which are powerful anti-inflammatory meds, are the main treatment. They help get the inflammation under control. Sometimes they have to use other medications to suppress the immune system too, if the steroids aren't enough.
Okay, so that was a whirlwind tour of restrictive lung diseases. Now we're at the very last section of the chapter, which has a bunch of other pulmonary conditions that don't really fit neatly into any other category.
It's like the miscellaneous section.
The first one on the list is acute respiratory distress syndrome, or ARDS. Sounds pretty serious.
It is. It's basically a really severe sudden lung injury that causes the lungs to fail very quickly.
So the lungs basically shut down.
Yeah, pretty much. And a lot of different things can trigger ARDS severe infections like sepsis, trauma. If someone breathes in vomit or water, we call that aspiration, near drowning, even breathing in toxic fumes.
So what exactly happens in the lungs with ARDS?
Those little air sacs, the alveoli, remember? They get inflamed and fill up with fluid, making it really, really hard to get oxygen into the bloodstream.
It's like the lungs are drowning.
It's exactly what the symptoms. Usually people with ARDS have terrible shortness of breath that comes on really fast within a day or two of whatever triggered it. They often have a rapid heart rate, a fever, and a cough that produces this foamy pink sputum.
So it's pretty obvious when someone has ARDS.
Oh yeah. To diagnose it, they look at the symptoms, do a chest x-ray to see those fluid-filled lungs, and check the blood oxygen levels, which are usually really low. Treatment for ARDS is pretty intense. They often need to put the patient on a ventilator to help them breathe while they try to figure out what caused it and treat that underlying problem.
Sounds like they have to work fast.
They do, and unfortunately, a lot of people with ARDS don't survive, especially older folks or those with other health problems.
Okay, let's move on to something that's a little less intense, although I'm sure it can be scary, especially for parents aspirating foreign bodies.
Yeah.
I remember when my nephew was a toddler, he swallowed a penny.
Oh my goodness, I bet that was terrifying. So aspiration is when something that's not supposed to be there gets breathed into the airway. It could be food, a little toy, even a tooth. And it happens a lot in little kids because they put everything in their mouths.
Right. They're still learning what's food and what's not. The chapter talks about the Heimlich maneuver to help someone who's choking, which is definitely something everyone should know. But what if the object gets stuck further down?
Then it gets more tricky. It might block the airway, making it hard to breathe. And if they don't get it out quickly, it can lead to other problems like pneumonia or a collapsed lung.
So it's not just a choking hazard, it can cause other lung issues.
Exactly. And usually to figure out if someone has aspirated something, they have to put a few things together. Did anyone see them swallow anything? What are their symptoms? Can they hear anything unusual when they listen to the lungs? And sometimes they'll do an X-ray to try and see the object.
And how do they get it out?
Usually they use a bronchoscope. Remember that tool that lets them look inside the airways?
Yeah, it's like a tiny submarine for the lungs.
That's a good way to think about it. They use that bronchoscope to see the object and then use little tools to grab it and pull it out.
Wow, it's like a tiny surgery. Okay, last condition on our list, hyaline membrane disease, which they're now calling respiratory distress syndrome, or RDS. Sounds like this one affects babies.
You got it. RDS is the most common reason premature babies have breathing problems. It's caused by a deficiency of surfactant. That's a substance that helps keep those tiny little air sacs in the lungs open.
Right, so without enough surfactant, those air sacs collapse, and it's really hard for the baby to breathe.
That's exactly right. And that's why premature babies whose lungs aren't fully developed are more likely to have this problem.
What are the signs a baby has RDS?
They usually have those classic signs of respiratory distress, really fast breathing, retractions where their chest pulls in with each breath, and grunting sounds. And on a chest x-ray, you see what we call diffuse atelectasis, which means those little air sacs are collapsed. It gives the lungs this ground glass appearance.
And what's the treatment?
The first thing is supportive care. They often have to go to the NICU, the neonatal intensive care unit, where they can be watched closely and get extra oxygen. And the biggest advance in treating RDS has been the development of something called exogenous surfactant. Basically, it's a surfactant that's made in a lab, and they can give it to the baby to help keep those air sacs open.
It's amazing they figured out a way to replace the missing surfactant.
It is, and it's saved countless premature babies. Well, I think we've pretty much covered everything in this chapter. We've talked about so many different lung conditions, from the common ones like pneumonia to the rare ones like pulmonary hypertension and IPF. We've talked about how they diagnose these conditions, how they treat them, and even how important it is to prevent them or catch them early.
I know. We've really gone deep into the weeds of pulmonology today. The theories, the research, even those specific case studies. But we've also tried to pull out the key takeaways and explain everything in a way that's easy to understand.
Absolutely. We want to make sure our listeners understand this stuff and feel empowered to make good decisions about their own health and to advocate for better lung health for everyone.
Well said. So remember, folks, knowledge is power. Keep learning, keep asking questions, and keep those brains buzzing. And thanks for joining us for this deep dive into the fascinating world of pulmonology.